Hey everyone, and welcome to Pineapple Support's presentation on suicidal ideations, what types and what you can do. I will be your presenter today. I'm Nicki Line, or Therapist Nicki, or the Healing Unicorn, various other acronyms, and let's get on into it. So who am I and why can I present on this? Well, I'm a licensed mental health counselor in the state of Florida, as well as an associate license in Georgia. I'm a board certified sex therapist. I'm also a certified geek therapist and therapeutic game master. And I work with Pineapple Support. I lead groups, I see individuals, and give trainings such as this. So big trigger warning for this presentation. I am going to be talking about suicide. I am going to be talking about different methods that people may be saying things or doing things to harm themselves, kill themselves, or the new term, unalive themselves. So just giving that trigger warning so you know it's coming up. I like to do that for my groups as well as presentations to know that we are going to be talking about some sensitive topics in here. The brief outline for today, I'm going to go over definitions, different examples of behaviors, ways to help, different resources, as well as I'm going to give you examples from my own personal experience. If I talk about clients or patients, understand that big details have been changed. So we're not violating HIPAA. There will be no names mentioned. If there are names, it won't be their real names. For example, if someone was, say, a nurse, I'm going to say they were a construction worker or something like that along those lines. So all the details are changed to protect everybody. And I also have permission for different stories as well to tell in here. Please PM me in the chat if you have questions or any specific scenarios. I know doing it in the big chat is intimidating because a lot of people don't want their details put out there, and I will check those at the end of the presentation to see if there are any, so I can answer those questions for you and give you what you're looking for. Excuse me, I have like dry mouth and getting over all the nastiness around here. So suicidal ideation. As a community, it's important to discuss and understand suicidal ideation, as well as understanding the difference between what is active ideation and what is passive ideation. It can be confusing and scary not knowing when to hold space for someone versus when they may need to get more qualified help than you can offer. And from here on, you may see on the slides that I say SI, that means suicidal ideation, or I may even say SI, or suicidal thoughts. These are used interchangeably. So suicidal ideations or thoughts, they are means of having thoughts, ideas, or ruminations about the possibility of ending one's life. It is not a diagnosis. It is a symptom of some mental disorders. It can also occur in response to adverse events without the presence of a mental disorder. There are different ways that people can experience this suicidal ideation or thoughts about killing themselves. So if we look at suicidal ideation, it is on a spectrum. So over the past few years, conversations about suicide have become more common, but it's still a topic people don't like talking about. So yay that September is Suicide Prevention Awareness Month, hence why we are talking about this today with Pineapple Support. And we decided to go in the suicidal ideation part because we do have several other courses that are on suicide and suicide prevention. So this will go into more of the whole spectrum and what can be done along the course of the spectrum of suicidal ideation. Suicidal ideation, again, is a broad term that has a lot of different meanings, and it contains a range of thinking, preoccupation with, or wishes about death or suicide. The definition is vague and broad in order to include all the many types of thoughts that enter this space. So if you look at the slide, you will see the suicidal ideation spectrum, where we go on the green end, where there's no suicidal ideation. where it's a normal focus on end-of-life issues due to advanced age or severe medical illness. You're going to have occasional thoughts of own mortality, especially if you've come across, like, let's say a car accident and your life flashes before your eyes with, oh my gosh, that could have been me, that could have happened, that could have been death. It does not feel that there would be better off dead. So they don't have the, oh, if I wasn't here anymore, things would be fine type deal. And, you can check in with people every once in a while if they start like looking sad or things like that, to say, hey, how are you doing? What's going on? Just listening. So then we go to passive suicidal ideation, which are thoughts that life is not worth living, that would be better off dead. As an example here, I pray to my God to take me soon. Has not thought about harming themselves. So with this would require further evaluation. If I was in a therapy room with someone, I would be asking much different questions, which I will go into later on in the presentation. Right now, this is just to get you familiar with the spectrum. Active suicidal ideation has considered a method to harm themselves. They might have thought about, oh, I could take pills. I have a revolver somewhere. It does not report a specific detailed plan yet or current intention to harm self. Demonstrates reasons for living and good impulse control. It does require an immediate evaluation. There are some other things that I would put into play as a therapist if I can evaluate for active suicidal ideation. Then you go all the way to immediate suicide and risk. This is active suicidal ideation. They have a detailed plan or intent. They have a specified detailed plan, current intention to harm themselves, or they just don't have reasons for living or good impulse control. This requires an immediate evaluation and more than likely hospitalization for more evaluation and to keep them safe with that. So again, as I said on the spectrum, passive suicidal ideation, the big thing is there are very vague thoughts of not being around anymore. They do not have a plan. They don't have an intention. It's just kind of floating out there in the universe or in their brain. So that's why, the picture, there are no plans found. It's just a thought. It's just a passing thought. And then we go to active suicidal ideation, whereas as you saw on the spectrum and here, there are plans. They have thought about a way to kill themselves. They probably can formulate, this is when I want to do it. I have a specific day and time. So it's important for those close to an individual experiencing these suicidal thoughts to look for any behavioral changes. This is when you're going to start seeing different things. Sometimes active suicidal ideation may not be seen and what is sad, but instead what the person does is, you have to, not exactly what they say, but look at the behavior, what they do, because actions speak louder than words, right? So if they're starting to isolate themselves, the old adage is they're going to be giving things away. They may be writing notes, things like that to say goodbye, making special trips or things to be like, hey, it was good to be around you. You meant so much in my life, things like that. Those are things to watch out for. If anyone ever makes the statement, like everyone will be better off without me, but they are doing things with changes in their behavior or mood, is increased isolation, like I said before, giving away items that they love, increased substance use or risky behavior, or even increasing passive suicidal statements. This is a big red flag or banner that there are more serious things at play here. So what does passive suicidal ideation look like? So different statements could be, I hope I do not wake up in the morning. My life has no purpose. I want everything to stop. I don't want to be here anymore. With that, if I hear those in the therapy room or even in passing with friends or family, I would say, hey, tell me more about that. Like that statement concerns me. Can we talk about it more? And with that, they may say, things have gotten really bad in life. Usually people will open up because they're wanting to have that type of conversation with someone, just like it's really hard. A lot of people in like the therapy room or with other people, they're scared to say these particular things because they're afraid of automatically going to the hospital, or I'm going to Baker Act them or 1013 them, depending upon what country or state you're in. Involuntary hospitalization is called something different. And I have to let them know that just because we're talking about this doesn't mean that I'm going to involuntarily commit them into a hospital. I don't like to do that because sometimes it hurts more than helps, to be quite honest. Oops, wrong way. Is that the wrong way? Okay, I didn't include the other thing. I thought I made a different slide. And look at different behaviors as well with passive suicidal ideation. They're going to start engaging in more risky behavior, possibly. With someone with passive suicidal ideation may fantasize or frequently think about death and dying. This can include imagining themselves dying in many other ways other than directly killing themselves. For example, they might imagine getting into a car accident or a plane crash. Passive ideation can cause people to take actions that suggest they don't care about their safety or their well-being. And this can look like neglecting basic needs and again, or riskier behavior. So it can be intentionally not wearing a seatbelt when driving, or driving recklessly with abandonment. I've had an individual before tell me that they were racing up and down the Gandy Bridge here in Tampa, just hoping that maybe they would get into an accident and go off the bridge. That is very risky behavior and almost active. It's going from passive to active suicidal ideation. They're going to engage in risky substance behavior usage. So increasing alcohol or different kind of recreational pharmaceuticals are going to be increased, where it's okay, I have nothing against, doing certain things for recreation, but if we're increasing this behavior and it's to numb out, to not feel things, to just be here, but not present, then we have a problem. It's no longer for entertainment. It's now being used to self-medicate, which is a bigger issue. Intentionally putting themselves in unsafe situations. For example, going on a walk at night in an unsafe area, going into, a park late at night in certain places is not very safe, especially like here in Tampa, we have gator warnings on our parks at night that are by the canals. So if we go for a walk at night and we don't have lights or anything, that's pretty unsafe because there are animals that will attack you. Neglecting to follow through with the treatment plan for conditions. So that could be for people who are diabetic, they're not taking their insulin. People who have high blood pressure, they're not taking their high blood pressure medication. Or individuals who have certain mental illnesses that are taking psychiatric medications. They're not taking them anymore because what does it matter? Some things from pop culture that may show passive suicidal ideation. If anybody's ever seen the show Supernatural with Sam and Dean Winchester, I'm a huge fan. So I've pulled a lot of stuff from there. Sam in season 1, he's the more intellectual brother. He watched his girlfriend die on the ceiling, same way his mom died. That he never saw his mom. He was a baby, but his fiance Jessica died in the same manner. So throughout the first season, it's dealing with Sam's depression and his guilt, and he will intentionally put himself in harm's way. He'll be the first to charge into a fight. He will take unnecessary risks because he doesn't really care anymore, because he's blaming himself for others' deaths. That is passive suicidal ideation in what pop culture would look like. So passive versus active suicidal ideation. They might know a specific method that they're going to kill themselves. I know we've gone over this before, but it's trying to hit home what are the big differences to watch out for. They have access to a method or plan to access it. They might have even chosen, like I said before, the date and time. People with active suicidal ideation need emergency care because they may be in imminent danger for taking actions to kill themselves. But passive ideation should also not be taken less seriously, but it needs to be met with support. Just because someone is saying, hey, I don't want to be here anymore, is not a reason to take them to the hospital at that point. But you do need to monitor it, or just check in with them, or say, hey, maybe you need to talk to a therapist, and suggest certain resources for that. Otherwise, it could worsen or become active, because then it's like, oh, if you're not taking it seriously, nobody cares. So see, I would be better off. That's that thought loop and trap that people get stuck in when they're in that depressive state. It's like, oh, they're looking for reasons to reinforce that negative cognition that they have, or that negative thought of, okay, no one really cares. There was a documentary about an individual who survived jumping off the Golden Gate Bridge. And if you've ever seen the Golden Gate Bridge, it's really high up. We're talking about hundreds of feet above the water. And it's become a popular spot for people to attempt suicide or commit suicide by jumping off the rails. They've since installed a bunch of other different things. But in this survivor's account, when he was in an active suicidal state, he got a taxi. He even had a cell phone on him. He was waiting. He was texting people different things. The taxi driver looking for anything for help to not do this. But he was caught in that thought loop. Even so much as he was waiting for the taxi driver to say something as he let him out at the bridge. The taxi driver didn't say anything. And then when he decided to go through with the act, when he was in the middle of the fall, he thought, I don't want to do this anymore. This was a bad idea. And unfortunately, most people, when they're halfway going off the bridge, it's too late. So being able to check in with somebody and saying, hey, how are you doing today? Even with my passive SI clients, if they make an inkling of it, I'm like, hey, just checking in. How are you doing? And to say, well, it's a crappy day. Okay, and then we do different exercises, like what are some things to be grateful for, different things like that, if they're going to engage in that. And a lot of people who have never felt suicidal ideations or had that deep depression, they don't know what it feels. They can't empathize. They can't put themselves in that place of understanding that things can be so dark that just ending it all would be better. Not knowing what's on the other side of life is much better than what's going on now. So while the definitions I've given are helpful in understanding the suicidal spectrum, they don't always depict what it actually feels like in that experience of these types of thoughts. Some clients describe suicidal ideation as like a shadow that's always following them around. Sometimes the sun hits just right and the shadow disappears for a while, which is why I have these particular pictures up here. When the sun is directly, shines just right, there is no shadow. But when the sun moves a fraction of a degree of the way, the shadow comes back. Others describe their suicidality as not wanting to die, but just wanting their pain to stop and feeling like it's a never-ending tunnel and they just want to get out. In a particular instance, a former patient stated the thought of not being hovered in her mind constantly. She said, I struggled with thoughts of my not being good enough and the thought life would be easier if I were not around anymore. She said, I reached out to a loved one and told them about my thoughts of ending my life. They took away the means of which they thought I would use to end my life. Sadly, I still found another way to move forward with hurting myself. And this particular patient did have some self-inflicted injuries, but then admitted herself to partial hospitalization program so she could get help. She learned that a lot of these were the effects of a traumatic brain injury, which is not uncommon for those who have TBIs or traumatic brain injuries to start having those thoughts. But she was able to pull herself out of her depression and what was happening and further her life. So she's now trying to help people in the counseling profession. So what causes passive suicidal ideations or passive SI? Well, there's a lot of factors, like having a mental health condition. So living with mental health conditions such as major depression can increase the risk of having passive suicidal ideation. Depression can decrease motivation to do things that can give you joy. It also leads to negative consequences like job loss, relationship challenges, and these consequences add additional stress and decrease social support. There was a study done in Thailand on older adults, and they found there were different types of predictors for suicidality. Major depressive disorder was a big predictor of suicidal ideation. However, other things such as agoraphobia, which is the fear of leaving the house, and poor perceived social support were more pronounced among individuals who have suicidality or who have these thoughts of killing themselves and not being here anymore. Other mental health conditions that can exacerbate things besides depression, individuals with bipolar disorder, borderline personality disorder. Individuals with BPD tend to lean more into self-harm versus suicidality, but it does happen. Individuals that may have schizophrenia also as well. There are a plethora of different disorders where suicidal ideation can be a part of it. Also, certain medications, certain psychiatric medications can increase thoughts of suicidality, which means that medication is not good for that person. They need to make an appointment with the psychiatrist right away to discontinue use of this medication because it's not helping. It's actually making things worse. And for medications, knowing as you're right as a patient or anybody's right as a patient, you can refuse to take this medication. Just because somebody who has doctor or a degree behind their name, they're not the be all end all of knowledge of what's happening with you, because people have different chemistry needs. So just an aside, if you do take psychiatric medications or are looking to take them, I would definitely recommend taking a DNA test to screen for pharmaceuticals, like which ones work best with your body's chemistry and DNA. That will actually help your psychiatrist out a whole lot too, so they don't have to do as much of a roulette game of figuring out which medications are best suited for your chemistry in your body. Other things that can cause passive suicidal ideations are dealing with difficult life challenges and circumstances. So financial troubles, going through difficult legal situations, like divorces or domestic violence, getting fired from a job, going through a really hard breakup, experiencing the death of a loved one. These are all different life challenges that can come up. Other things such as surviving traumatic events. In general, experiencing trauma puts someone at higher risk for having suicidal thoughts, specifically childhood trauma or early life adversity has long-term risk factors for suicidal behavior. Childhood trauma survivors may struggle with self-esteem and experiencing negative self-talk. These are both connected to suicidal ideations. I'm also going to go say individuals who are actively in the military, who are also EMTs, law enforcement, firefighters. For one, they are at risk at having traumatic brain injuries, but also having PTSD with that, and that can increase suicidal ideations and behaviors for all of those, especially if they were survivors of something that could happen, or they witnessed different acts that the lay person who is not involved in those fields would see. If they're experiencing discrimination or not feeling accepted. So being a part of marginalized communities can be associated with passive suicidal ideations, such as the LGBTQIA plus community definitely has a high risk of passive suicidality, as well as attempting suicide. Those who experience racial trauma may also experience suicidal ideation, where it's, I'm not accepted, I would be better off not here, I'm never going to get out of this type of wheel. One thing is chronic pain and illness as well. You see a lot of individuals who are wanting euthanasia, or back when I was younger, Dr. Kevorkian, or the Angel of Death, or Dr. Death. He was really big at assisting individuals in fulfilling suicidal ideations at the end of life due to terminal illnesses, chronic pain, where they just want it to stop. And there are others that I may not have listed here as well. So why should we take passive suicidal ideation seriously? Someone with passive suicidal ideations, they're still at risk for attempting suicide. So they're still on that spectrum that we showed earlier. Experiencing even passive suicidal ideations is considered one of the top risk factors for attempting suicide. It's common for suicidal thoughts to fluctuate and change. So it can be hard to predict when someone's passive suicidal thoughts will increase in intensity. We also don't have a good screening for tests for predicting. Like, we can ask certain questions, but if someone is really wanting to evade those questions, they're going to know how to answer them to not, raise red flags of awareness. Additionally, someone experiencing passive suicidal ideation may engage, like I said before, in risky behaviors. So you need to keep a lookout for that. So what can we do if a loved one is experiencing passive suicidal ideations, or if someone on set or someone that you work with, friends? So if you're concerned that you or a loved one may have passive suicidal thoughts, there are many actions that you can take. For one, we need to take the shame out of suicidal thoughts. If you are experiencing, or if a loved one is experiencing passive SI, it's important to remember that those thoughts are an expression of pain. They don't make you or your loved one abnormal or bad. And people with passive suicidal thoughts still deserve support and a non-judgmental space to discuss these thoughts and feelings. So just because someone is having these thoughts, they're not a burden. They are in a lot of pain, and they need a space to express this pain, to work through this pain. Don't be afraid to ask about suicide directly. I remember growing up, suicide was tiptoed around. We didn't talk about it a whole lot. I didn't understand it as a child until classmates that I knew, like in high school. Actually, I think the first time I heard about one of my classmates attempting suicide was in middle school. and I didn't really understand. My parents didn't explain a whole lot. So it was like this hush hush thing. We don't talk about mental illness. Again, I grew up in the 80s and the 90s. So it was still a thing like we don't talk about mental illness. If someone you love says that they wish that they were dead or takes action to put their life in danger, ask them directly if they're having thoughts of suicide. Asking and talking about it will not increase the likelihood that their suicidal thoughts will intensify. In fact, your loved one may even be feeling relieved that they don't have to struggle alone, that someone gave them permission to talk about it. It's not treated as something that's bad or shameful. It can alleviate a little, some of the pain at times of what's going on. If a family member or friend, coworker confides that they're actively planning suicide, take it very seriously. Seek professional help immediately. Don't leave the person alone. Like, this is if they're actively, like, they have a plan, they have an intent. Don't leave them alone until they talk to a mental health professional, or they can get some kind of evaluation, because depression and things that where suicidal ideation is a symptom, they are serious medical conditions and need to be addressed. How to behave when somebody is confessing this to you or confiding in you. They're being very vulnerable. Show compassion instead of ignoring the situation or acting angry or shocked with the person for having suicidal thoughts, because that's going to reinforce, if you're acting angry or shocked, that's going to reinforce the I'm a burden, I shouldn't do this, that whole thought pattern, instead of just sitting there with them, being either neutral or showing that compassion. Someone planning to end their own life is in desperate pain and wants the hurt to end. Suicide is not about ending a life. It's about ending the pain of severe depression or physical pain or any of the other things that we have discussed. When I'm in the therapy room with somebody and they're expressing passive suicidal thoughts, I will actually dig in a little deeper. Like, hey, so you said this, like one of the big things are doorknob confessions, where clients or patients will, while they're leaving, go, oh yeah, by the way, I just don't feel like I want to be here anymore. And it's like, wait. I needed you to say this like at the beginning of the session so we could talk about this. So I need you to come back in now and we're going to need to talk about this. Like when you say that you don't want to be here anymore or things suck, or it's more than just a, excuse the cursing, fuck my life situation. That's all right. So when you say you don't want to be here anymore, what does that mean? Like, I have to do my due diligence in exploring this. And most people understand, and they tend to want that. That's why they're giving these, I don't want to say crumbs, but that's like they want you to dig sometimes. And it can be, okay, so when you say this, what does this mean? Have you thought about ways to, commit suicide? How do you have a plan? And if these things are all in order, like they do have a plan, they've thought about it, then I will go in more in depth. Like, okay, so you want to drown yourself, or you want to, go into traffic, a plethora of other ways. And I really dig in and say, hey, what do you think this is going to feel like? Because a lot of people just think it's just drifting off to sleep, and that's no. It's more intense than that. So actually exploring it and people starting to realize like, oh, this is a real thing, can sometimes pull them out of it, or we're exploring what's going on. I tell them I don't like to Baker Act or give involuntary hospitalizations. So we really need to talk about this, and we really need to make a plan, which is why at the very bottom of this slide, I have make a safety care plan. I have a whole video for clients on how to make a safety care plan. And this can be for intense anxiety. This can be for emotional regulation. This can be for passive or active suicidal ideation. I try to stay away from saying a safety care contract or a safety contract or contract for safety, because usually when individuals hear that, they put up a wall and like, no, I'm not going to do that. And then we have to put other things like, if you can't do this with me or agree that you're going to stay safe for 24 hours, there are other things that we'll have to put into play. So with making a safety care plan, anybody can do this. It's not difficult. I like to use what's called the triangle of safety. So at the very top of the triangle or pyramid of safety, I'll put, hey, for one, what are some big things that let you know that you're going down this path, that you're having suicidal ideations? It could be I'm isolating, I'm not engaging in my hobbies anymore, my negative thoughts increase, but that's for them to fill out so they're more aware, they have more insight in what's going on with them. Then we look at internal coping strategies. And these coping strategies don't involve anybody else. We're not reaching out for other people at this point. We're looking at what can I do so I can, if we're going with dialectical behavioral therapy, we can use TIP, which the T is temperature, intense exercise, paced breathing, progressive relaxation. All of these different things are internal coping strategies, or we can color, we can find a different distraction. Then we look at, now we're going to go from internal to external. So who are people in social settings that provide distractions? These might not necessarily be people that you confide in, but they're people and places and things that offer a distraction. So it could be if someone is struggling with addiction, they could be going to a 12-step meeting or a SMART meeting. Or it could be, hey, I'm going to go play a game with somebody. I'm going to have game night with some friends just to have entertainment and get out of myself, to have that social support in situations. Usually I would want 3 of these, like 3 of all of these actually. So in case one is not present, we have something else to fall back on. We have a backup for the backup. Next is, who are people that I can ask for help? So who are those friends and family members that you can be vulnerable with, that you can open up to, that are going to be non-judgmental and give you that space to talk about what's happening with you? And then we take a step down. What are professionals and agencies we can turn to in a crisis? So that would be a therapist. That would be crisis hotlines, things of that nature, and have multiple on my safety care plan. And I'm happy if anybody wants the template that I use for this, I'm happy to send that to you. Just shoot me an email. I'll have my email at the end of this presentation, and I'm happy to give you that template. On the ones that I use, I have the national hotline for adults. I have ones for adolescents. I have, depending upon the person, I have specific ones for different needs. I need to update it because now we have 988, which is, well, in America, it's the new mental health crisis hotline versus 911. So now we have different individuals who are answering these phones. So after turning to professionals and trying to avert the crisis that way, now we look at how do we make the environment safe if that's not helping or in conjunction with doing this. So if the intent was, hey, possibly taking pills, we need to remove the pills or we need to lock them up. And the key or the combination is not with the person who is in crisis or is having the suicidal ideations. Same thing with any weapons or any means that this would happen. Beyond creating a safe environment, if that does not work, now we do need to go to the hospital. We need to call someone for either hospitalization. We need to go to a hospital or an emergency room to get evaluated for that. If someone doesn't want to go, then that's a whole other gambit of calling law enforcement professionals and things to get this ball rolling to help someone save themselves, or helping you help them in a way. Also, when they make this particular safety care plan, I tell them to give it to somebody, to give it to the individuals that you can ask for help, or someone who is living with you, someone who's close to you, so they have access to the plan, as well as the individual either keep it in their self-soothe kit, which I have a link to that, or the link in this presentation as well. I'm also happy to put it up in chat after I'm through with the presentation, say, hey, we had, and this will help with the internal coping skills as well as distractions. But we keep the plan in there so we don't have to engage our thinky parts. Because when someone is flooded or emotionally dysregulated, they are going back to their lizard brain or their amygdala. They are not thinking clearly. They're not engaging the prefrontal cortex, which is our thinky parts, for people to actually engage in problem solving skills. So different resources that I've talked about, there's actually the crisis counseling one is on the Golden Gate Bridge now, where they have phones put up. They saw a significant decrease in individuals attempting suicide or attempting to jump once they install these phones on the bridges. Because again, they're asking for help. It's a last ditch effort to be like, hey, I'm reaching out, I need help. So in America, we do have a new suicide crisis lifeline, which is 988. There's also the National Suicide Prevention Lifeline and the website, suicidepreventionlifeline.org. I know not everybody who is going to be watching this is going to be in the US. There are other resources as well. The particular website that I have up here is the International Suicide Hotlines, and they have them for almost every country, or they have a link to the particular country. I think Canada has its own link to go to their pages on there. I have the link for here for the self-soothe kit video that I've made, as well as the safety care plan. I also have a link tree specifically for individuals who are in sex work. And I'm happy to add things to this as needed. So these are all different resources that you can provide somebody. Like, hey, here you go. I'm giving you a lifeline. I'm giving you help, because you can't do it for them, right? Like this is what I can do. I can provide you a space to talk. I can tell you when this has gone beyond my scope of help and I need to refer you to a mental health professional or somebody who has more experience in this than you do if you're offering support to them. And that's knowing where your limit is. Like, you don't have to like be the be all end all for an individual who is having passive or active SI. So know where your spoons are, know where your limit is, as well as, hey, these are the resources that I know of that I can give you. So you don't have to be all in. And here's a big question that I get from some people and family members. What if they refuse? Well, if they refuse, you can't make them. Like, sadly, if they're going to refuse help, you can't force them to get help as much as we wish we could. All we can do is continue to provide support and resources when we can, and set boundaries for ourselves if needed. However, if a person's suicidality increases to the point where they are at risk to their own safety, you may need to alert local authorities to assist that person, while also understanding that may cause harm to your relationship. In the end, it's about helping the individual. I fully understand that if I involuntarily put somebody in a hospital, I'm probably damaging my therapeutic relationship with them. I'm willing to do that for their safety. Like, I'm fully aware. I do have some individuals that said, if you ever Baker Act me, then my relationship with you will be done. And I said, okay, I fully understand that. And we will exhaust all options before that happens. But understand that that's going to be part of the conversation. You can't put limits on me for that. So that's with those boundaries. And we have that understanding with one another. So again, like we said, the safety care plan, you can give them resources, you can support them within your limits, as well as, hospitalization. You can have someone have a welfare check done. This happens a lot with some people. Sometimes they use emotional blackmail, or they are actively in pain, where they're saying, well, I'm just going to go hurt myself. Okay, fine. I take that very seriously. And I say, hey, I'm going to have someone come do a welfare check on you with that, especially since I do a lot of telehealth. I don't always have the means to be right there with somebody when they say certain things. So I have to have that outlet and have that resource available that I can have someone come check on you. Or I'm going to check on you in 30 minutes. I'm going to check on you in an hour. And I ask if that's okay. I do ask consent for that from the person so they know that I'm going to do that. And it's okay for you to do that too with somebody. If you're not feeling comfortable with how the conversation is ending, say, hey, can I like text you and check on you in 15-20 minutes, or can I check on you daily? And you don't even have to answer me. You can just send me an emoji. You can send me a thumbs up, you can send me a heart, you can send me a thumbs down, so that way you're not having to actively go through all the things again. So some of the takeaways here is understanding that suicidal ideation is on the spectrum. It goes from none all the way over to immediate danger. We need to get them help now. Passive suicidality needs to be taken seriously, not being dismissive or minimizing or saying, hey, oh, that's really not that bad. It needs to be talked about, and there's no shame in there with that. Again, take the shame away from the conversation about suicide. Show compassion. So show that empathy if you can. I know it's not easy for everyone to show empathy, but saying, hey, I'm here for you. I know this is really hard. You must be in a lot of pain. Let's talk about this. Have a safety care plan. It is proactive. I would rather them have it and not need it than not have it. I think I said that wrong. I would rather them need it and not use it instead of not have it and then need it later on. Because again, thinky parts aren't engaging when we're flooded and when we're in that dark place. And provide resources within your capability. Remember what your scope of care can handle, what available your emotional, physical, financial spoons that you have to help somebody, and stay within those limits. It's okay to say, hey, I can't go any farther, but here are resources to take you farther, or I can introduce you to someone who may be able to help you farther than I can. So I understand if you're not feeling comfortable to ask questions directly in chat or in PM, if you had something happen to you or something that's happened in your life or somebody else and you wanted to ask a specific question, you are welcome to contact me at different forms. I have my email is therapistnicki@harmonyusinc.com. You can also direct message me or PM me on Twitter at Therapist Nicki. You can also look at our website, which is harmonyusinc.com, and contact me through that website if you would like. I think my information is also on Pineapple Support, or you can reach through Pineapple Support and have them contact me. So different ways, if you do have a particular question or scenario that you are asking about, I would like to help you with that. So don't be afraid to reach out. If you're part of the Monday night group, you're welcome, or if you would like to be a part of that, you just have to go through Pineapple Support and they will give you the links and everything that you need to be a part of that Monday night group. Well, thank you, everyone. I do appreciate everybody participating and making comments if they needed to or they wanted to, as well as giving me the space to give this presentation for everyone. I do feel it's a misunderstood thing with passive suicidal ideation, as well as going into active. And individuals don't really know how to interact with that when somebody says these certain things, or they don't know what to say besides providing a safe space. So I'm hoping this presentation helped a little bit on that. Again, if you have any additional questions or comments, or this happens to me a lot when I'm done with the presentation or I've finished watching one, I'm like, oh man, I should have asked that. So I am encouraging, please, if you want these slides, I'll be giving them to Pineapple Support, so you can ask them for that, or you can ask me directly for the slides for like the resources and things like that. Or if you have other questions, please email me, DM me. I'm here to help. You just have to reach out and ask. I don't know how to help if nobody reaches out. Okay. So again, thank you all, and I look forward to giving more presentations in the future. Bye, everyone.